Hello everyone and welcome to the latest episode of Let's Talk Blood Cancer, the Patients Podcast. My name is Adam Joyce and many years ago I survived blood cancer, and now I'm in the very privileged position where I get to share this sofa with some very esteemed guests. And today is no exception, because joining me today is Professor Steve Knapper, a consultant haematologist at the University of Wales. Steve, welcome to the Patients Podcast. It's great to have you here. Now, I've only just scratched the surface of what you do, Steve. Tell us a little bit more about yourself.
So as you say, Adam, I'm a haematologist, so I'm a doctor who specialises in treating patients with blood cancers. Haematology is a kind of super specialised field now, so we all have particular areas of interest within blood cancer. So I specialise in what we call myeloid blood cancers, particularly a disease called acute myeloid leukemia. And I'm fortunate enough that my role, as well as being a clinician, I'm also a clinical academic. So it means a certain proportion of my week I get to spend doing research type activities. So I work for Cardiff University for part of my role, the academic part of my role.
Thank you, Steve. And was it always haematology that you wanted to get into, or was that just sort of a natural progression for you from what you were doing previously?
It was actually a reasonably late decision to do haematology. So like a lot of junior doctors, now called resident doctors, we have to be careful there, I embarked, following my house jobs, on what was called a medical rotation. So I was doing a few months going through different specialities as what was then known as a senior house officer. I was doing that in Taunton in Somerset, which was a fantastic place to live for a few years. And the haematology attachment on that 2.5-year rotation was the very last job. Mm-hmm. And I almost left the rotation before I did haematology, and it was due to a combination of things, but particularly failing my MRCP exam, which meant I stayed on a little bit longer and did the haematology attachment. And I just found I absolutely loved that speciality.
Well, so you might not have done the haematology
I may not have done it at all,
successful in the exams.
Because I possibly had a job lined up in a different speciality, which I won't say what that was. But no, so I did 4 months of haematology in Taunton, and I just felt like it was like a Dr. Water sort of thing. I really liked the fact that it was a relatively small number of patients that you got to know really, really well. They had a often fairly arduous journey, as you know, through some fairly toxic treatments, but you really got to know the patients and their stories really well and got to see them through some difficult moments. And also there's the lab aspect of it as well. So haematologists, probably unlike a lot of specialists, we're also pathologists. So we look at blood and bone marrow and are very much involved in the diagnostic process as well. So you get to see both sides of it. Okay. And it's a very kind of research-orientated speciality as well. So lots going on.
And you've mentioned AML, acute myeloid leukemia. That's become a specialism of yours. So for those that are watching who may not be conversant with AML, could you sort of break it down for us?
So it's a type of cancer of the bone marrow. So the bone marrow is where the blood is manufactured. Acute refers to the fact that it comes on quickly and often quite dramatically over a number of weeks, rather than chronic leukemias, which are more of a slowly evolving process. And what happens in acute leukemia, if you liken the bone marrow to a sort of factory production line, where cells start off as a very immature type of cell called a blast at the start of the production line, and gradually take on the features of mature red cells and white cells and platelets. What happens in acute leukemia is you get a block in that process right at the beginning of the production line. Okay. So rather than the normal cells being produced, you get a build-up of these blast cells, which are pretty useless, and they sometimes get into the blood themselves. But what that means is that people stop producing the normal blood cells. So they become anemic, their immune system stops working properly because of the lack of white cells, and sometimes because of the lack of platelets, they start being prone to bruising and bleeding. So we refer to that combination as bone marrow failure, and really that's the issue in patients with acute leukemia. And there are two main types. We call them myeloid and lymphoblastic, and they're very similar, but the main difference between them is myeloid tends to be more of a disease of adults, whereas lymphoblastic leukemia tends to be commoner in children. It's not universal, but that tends to be the main difference between them.
You explain that so articulately, and I guess over the years, having to explain that to patients, you've had to perfect that, haven't you?
Yeah, and it's very, very difficult, and it's no two conversations with patients and their families are the same. So everybody comes in with a different level of biological knowledge, and often they will come to me after they've already had conversations with a few other doctors and different medical professionals. So it's very much a sort of bespoke conversation where we have to gently probe how much people know already, and then really suit the way we... Not everybody wants to know everything in the same conversation.
And it must be so confusing for people at the start of their journey as well. Steve, you're part of the Trials Acceleration Programme. Can you tell us a little bit more about that?
Yeah, so it's something I've been involved with for, I guess it's since it first started, so it's more than a decade now. And I think back then there was a real sort of lack of coordination around the UK, particularly in how different big blood cancer treating sites were able to access clinical trials, particularly what we call early phase studies. So there were a lot of kind of islands of activity, but not much connectivity. And I think what the Trials Acceleration Programme did was really pull together people who were already interested in running clinical trials, but in a cohesive network. So 12, 13 sites could all open the same trials in a coordinated way. It was a platform that people could have ideas for clinical trials and potentially take them forward in the network. And I think the other really good thing it did was it funded particularly research nurses in those different trial sites, which really gave a momentum to getting those trials opened and getting this kind of almost like a team ethos, a kind of corporate identity, where people were all focused on getting all of the TAP studies open, and almost kind of a healthy degree of competition in terms of getting the trials open, recruiting to them well, and being seen to sort of make the whole exercise a success.
Yeah.
And I think it's really, and it's become more than a sum of its parts. So it's had various different slight changes of funding and identity over the last 10, 15 years. But over that period, we've seen this much greater cohesion, and there's a lot more early phase trial activity. And I think the TAP network is one of the big drivers for that.
And can you talk us through a trial, Steve? So from conception to the first patient being offered a trial. Tell us about that.
So I think clinical trials, they come in all sorts of different shapes and sizes and varieties. So there's no single way that trials go from that first idea to the actual recruiting the first patient. Some of them arise from ideas that have arisen from laboratory work that people are doing. Some arise because we know there are drugs out there that haven't been used in a certain way, and we see there are unmet patient treatment needs, and there's a spark for an idea for a clinical trial. And I think some arise due to approaches from the pharmaceutical industry. So they've got a drug where they're wanting to look at it in a new indication or for the first time in patients, and are looking for a network to then potentially run that study. So the ideas come from different places, and I think it goes through a number of stages. So usually there is a period of planning where the trial has to be sort of tested out, ideas for which patient population is most apt for that particular trial. There's a lot of modelling in terms of statistics and how many patients are going to be required for the study. At that point, there's quite a lot, increasingly, and really importantly, we involve patients and families with that process to work out what is acceptable, what is unacceptable, what patients want. And there's this balance of risks against benefits with how a new trial is designed. There's then the thorny issue of how we get a trial funded. Sometimes that comes from the commercial sector, from pharma industry, but a lot of times we have to rely on third sector charity funding, and that's all very competitive and very tightly regulated and reviewed. So that's a big obstacle we need to clear, and then there's a lot of regulatory approvals which have to be gone through. So there are ethics committees that review the protocol. There are also trial regulators. So in the UK we have something called the MHRA, which review new trial applications and have to give a clinical trials award before we take the trial further.
And at the heart of this is a patient.
Yeah, absolutely.
Which clearly, we'll talk about in a little while. Can you tell me about the term early phase? I heard you use early phase and appreciate the clue maybe in the title. What's that, Steve?
So traditionally, trials get divided into phase 1, 2, 3 and 4. And sometimes, generally, the early phase gets applied to the phase 1 and phase 2 studies. And these are generally trials involving smaller numbers of patients where we're testing very novel new drugs, new interventions, or drugs being used in combinations for the first time. So traditionally we have a phase 1 study, which is all about finding a safe dose for a drug or a drug combination, monitoring very, very closely for side effects before then being able to move on to later phases. So quite often in phase 1, we have to start at a low dose and build it up. So that sort of study may be not something which is suitable for patients who've just been newly diagnosed, where there are often quite a number of very successful treatments which they haven't tried yet.
Okay.
So those studies are generally for patients who unfortunately have exhausted conventional treatment options, may not have any conventional options left. Phase 2, which is the other early phase study, tends to be where we've established a dose and we've largely established safety, and we're then starting to look at the clinical effectiveness of a drug. And it goes through that phase before we then start looking at larger numbers of patients and comparing the new intervention with existing treatments. And that's where it crosses that boundary into late phase and randomised studies.
Super. Thank you. And you mentioned a minute or two ago about all of the different factors that come together to produce a trial and get it to a patient. But in your experience, Steve, what are some of the biggest hurdles that you face, or maybe we face together in our battle against blood cancer? The biggest hurdles of getting these trials out to patients?
I think one of the biggest hurdles, it's almost we're a sort of victim of success, because there are so many new drugs which have been approved for so many different cancer indications that often a trial can take a number of years to go through all these steps to devise it, to then recruit patients, then treat patients, and then report. And I think one of the things we have to be aware of is, are the findings from the trial still going to be relevant to the field of blood cancer in 5, 6, 7 years' time? And so we've had to design trials which are a bit more agile, which can be delivered fast. And I think one of the things about a network like TAP is that it's tried to come up with ways of accelerating this way these trials get reviewed and approved. So that's one of the big challenges. I think one of the other challenges is still getting funding for trials, getting buy-in. And I think the NHS is a very challenging environment at the moment. It's short of money. Different hospitals within the NHS have different policies in terms of which trials they will take on, whether they will take on non-commercial as well as commercial studies. And it's increasingly about the bottom line and being able to generate funds by running these studies. And I think that is a challenge for clinical researchers who are trying to fund studies. And so it's lots of different challenges, and getting these things coordinated and not allowing rate-limiting steps to emerge, which unexpectedly cause a 12-month delay. It's trying to keep everyone going.
And Steve, you said that sometimes the trials are offered to patients where conventional treatments have failed. I guess there must be more to the selection process or the recruitment of a patient, and it's not just confined to those where conventional treatment has failed. Would that be right?
No, so there's lots of different types of clinical trial. And I mean, breaking it down into early phase and late phase, ideally, We know that patients who are treated in clinical trials generally do well in comparison to patients who receive treatment outside clinical trials. And so ideally we would be able to offer a clinical trial to absolutely all blood cancer patients going through treatment. But there are a wealth of new of treatments which are now approved, and some very, very good treatments. So, and it's not, if you bear in mind that there are more than 100 types of blood cancer, and even within those 100 types of blood cancer, each one, particularly acute myeloid leukemia, which is my focus, it's actually a number of different diseases with a number of different gene mutations causing them. And clinical trials and treatments have become more and more targeted on smaller and smaller subgroups of patients. So having a trial open for every single subgroup at every single hospital is just not, unfortunately, a viable thing to do. So it's trying to keep as many trials open for as many patients as possible.
And you've just answered my next question that was burning for me, was why can't everybody just be offered a trial? And I think, as you've just said there's too much against you, isn't there?
Yeah, absolutely. So we would like to, but clearly it's got to be things which mean patients can have treatments as close to home and as conveniently as possible. And so it wouldn't be ethical for a patient to travel 100 miles to a centre just to do a clinical trial if existing treatments were fine.
Of course.
Where they were.
And we've spoken a little bit about research as well, and research nurses. Tell us a bit about their role and how vital they are.
I think research nurses are sort of the glue that holds the clinical trials together in an individual centre. So when a patient is recruited into a clinical trial, I think there is usually a named research nurse who leads on that trial in a particular centre, and they become the main point of contact for the patient. They're the go-to person that links everything together, is the person that the patient can phone or contact if there's any questions. And so I think it's vital. I don't think the trials would function without really good research nurses.
And is it as simple, or maybe I'm being naive, more funding, more nurses, more trials?
To a degree, but I think there are lots of different threads. So we talked about rate limiting steps, and for a trial to work at a centre, there's a whole load of different things which need to be in alignment. So you've got to have a pharmacy department which is funded well enough to be able to prepare the drugs and issue the prescriptions. You need a slick R&D department. You need medics as well. So you need consultants and clinical fellows who can see the patients and organise trial visits, etc., with the trial nurses. So, and there's a lot of administration and data collection and archiving and all those sorts of things. So it's a team effort. So one of the things that's been quite nice about TAP is, although the majority of centres, the money that's come through the TAP network from Cure Leukemia has funded research nurses, it's not a given that it has to be used for research nurses. So it's very much something that individual centres who are TAP centres can identify what their particular rate limiting step is, and if it's a early phase trials pharmacist or if it's a administrator, they can part spend the money on half of 2 posts or administer. So each centre, I think, has got its own challenges and knows pretty well what the rate limiting steps, and that might change, might be different in 5 years to what it is now.
And Steve, I'd like to focus. I mean, this is a question that's probably very bespoke to you as a person, and I'd like to know more about the conversations you have with patients when their options of conventional treatment have now expired. Some will be recruited into a trial, others won't. How do you have those conversations at those times?
I mean, I think it's a very bespoke situation for individual patients and their families. So in that sort of situation, I think it's always a little bit easier if you've built up a relationship, often over a number of months, with a patient and their family. And so when it comes to have that conversation that conventional treatments have exhausted, you've already got a kind of trusting relationship with them. And I think that's the point sometimes where early phase trials get mentioned. But I think we have to be honest and not overplay the early phase trials option, because it's not right for everybody, and we have to be realistic about what an early phase trial can offer. As we've said, sometimes early phase trials, like phase 1 trials, you might end up giving a patient a dose of a new drug which may ultimately not be a high enough dose to actually have much of an effect on the condition. So we have to be honest, and for some patients, going down a route of palliation and symptom control and allowing them time to spend with relatives and family and maintaining quality of life is the right thing to do.
Best treatment,
rather than travelling to sometimes a different part of the country and causing a lot of upheaval to go in to an early phase trial. So I'm not for a minute saying early phase trials should be downplayed, but I think we just have to be honest about what we offer and present the options and come to a decision. And often it takes a few days or even longer to go through those options.
Is there ever such a thing as a normal or predicted reaction from a patient if you are able to offer them a trial? Is it elation or trepidation?
It's all of those things. It's very different, and sometimes you'll be able to predict what that reaction might be based on the relationship you built up.
Yeah.
Some patients are very, very quick to grab any sort of lifeline in that situation if there is a clinical trial there, which could give a tiny chance of a response to treatment. They will want to jump straight for that decision so far. So in those cases, it's sometimes a case of tempering enthusiasm a little bit, playing devil's advocate a little bit, and talking about what the other options would be. Sometimes people are inherently very distrusting of clinical trials and see all of especially when they read very lengthy patient information sheets which list all the potential side effects in a very kind of legalistic way. So sometimes it's the opposite, and we have to pick through that a little bit and present more of a case for why an early phase trial might be a good idea.
Do you ever find yourself battling misinformation?
Yeah, sometimes. I mean, sometimes people will read things, especially people who potentially we haven't developed a relationship with, who've read things on the internet, sometimes things from other countries which don't apply so much. So there is certainly people come into that first meeting, especially if it's a patient that's been treated in another centre who's then come to, say, Cardiff in our instance, to meet us for the first time and think about an early phase trial. So there's sometimes quite a lot of information to disentangle before we...
And on the topic of difficult conversations, thinking about you as a person, are there any... I don't want to ask you to relive trauma, but are there any moments in your career that have particularly tested your resilience?
I think it's sometimes difficult to predict, and I think it very much depends on individual patients. And sometimes something that someone says or a particular set of circumstances around an individual patient is quite traumatic. I think probably the most general thing which affected me was probably having children and having young children for the first time, and then finding myself occasionally treating children or young children, which I don't do so much now. But I found that was a lot more traumatic when you've got a family yourself. And whereas I'd sort of treated children as a medical student and in my early career years before that, and I found that quite heart-rending, actually.
I bet there'll be many people watching this that can really associate with that in whatever field of work they may be in. During your career, Steve, what are the most dramatic changes you've seen in the world of haematology?
Yeah, I mean, I guess I've been here for quite a long time now, and you always think yourself as being kind of near the start of your career, but it's been a few years now. So I think the main thing that's changed in haematology, I think, is it's become so super specialised. And whereas when I started, you went into the sort of cancer side of haematology, but were involved in treating the whole spectrum of different cancers. But now it's very difficult to do that. I think haematologists who work in district hospitals, particularly rural areas, more general hospitals, they do a remarkable job because they're seeing patients right across the breadth of haematological cancers, whereas there have been so many new drugs approved, there are so many different pathways that it would be very, very difficult to keep abreast of absolutely everything. So I think the main change we've seen is just there's been this massive influx of new drugs, new targeted treatments, and also much, much greater understanding of what causes haematological cancers, the different gene defects, mutations, which have allowed us to develop all of these targeted treatments. And it's unrecognisable from where we were 20 years ago, say, which is fantastic. It kind of creeps up on you a little bit.
Well, we're using the timeline of 20 years ago. If we focus again on AML, if we look 5 years ago, and then I'll perhaps ask you to think 5 years in the future from now, what are your reflections?
Well, I think for the first 15 years or so I was involved in treating AML, we had hardly any new drugs approved, any new sort of game-changing medications. But over the last 5 years, we've had 7 or 8, or even possibly slightly more than that, new drugs approved, which have gone through the NICE approvals process in the NHS, and we've been able to add in or exchange for existing treatments. So that's been amazing. And I think in AML in particular, we've traditionally had this division between intensive and non-intensive treatment approaches. So intensive have generally been very toxic chemotherapy combinations, which are aimed at long-term cure, but because of their toxicity have only been applicable to a certain proportion of patients, whereas non-intensive have been very palliative medications that have just been able to control things for a certain amount of time. But what we've seen over the last 2 or 3 years are new regimens right on the borderline, where some of those non-intensive treatments, by adding in new targeted drugs, have suddenly become much more able to get deep responses and potentially head in towards the curative aspect. So I think what we're seeing now are these non-intensive treatments potentially used in combination, where we're potentially using up to 3 drugs rather than 1 or 2, where they're starting to take over from some of the traditional intensive treatments. And 5 years' time, it will be fascinating to see how much of intensive chemotherapy has actually been replaced by those types of treatments.
And that's the thing that I remember about my journey, and I'm sure every patient who's been treated with intensive chemotherapy will feel the same. It's absolutely awful. Can you see a time where we may be able to move away from those really horrible treatments?
I mean, I think we're already starting to see that a little bit, because there are certain disease. I mean, one of the types of AML I've involved in treating is something called acute promyelocytic leukemia, which is about 10%. And for a few years now, we don't generally use any chemotherapy at all in those patients, and that's given us a glimpse of how we can combine targeted treatments by understanding the mechanisms of the disease and using fully targeted treatments. So that is a particular example, but I think we'll start to see other examples emerging where we can very much dose reduce and potentially even get rid of intensive chemotherapy. We're not there yet, but we can. That's the way the wind is blowing.
It's exciting, Steve.
It is. It's fantastic. I mean, it's great to be able to, I don't just have this conversation and just reflect a little bit and see how things have gradually changed. So no 2 weeks are exactly the same, and you can just see things moving forward. And it's really
I'm inspired by your excitement. What are some of the biggest misconceptions about blood cancer?
I think people don't understand how nuanced it is and how many different types there are. So I think there's possibly this conception of leukemia as being the only blood cancer, and whereas leukemia is one of a number, but there's lots of different types of leukemia as well. And I think there's this perception leukemia equals chemotherapy, in particularly maybe children, rather than it's a disease which you see in all age groups. So I think possibly that's a...
What does success look like to you? Acute leukemia, the clue is in the title. We want to find a cure for blood cancers. But what's your personal success look like?
So I don't think we're going to get rid of blood cancers completely, but I think we're becoming much better at treating them. But I think the goal in any individual patient is probably, it's going to stay different for different sorts of patients. So there will always be patients where we're able to pursue cure, And I guess AML, acute myeloid leukemia, is an example of this, where we've got patients where we're aiming at pursuing cure, but we're trying to achieve it probably by minimising toxicity in how we go about that. And so shortening the duration of treatment, reducing the amount of side effects that people have in getting to that cure. I think there's also patients, particularly older, frailer patients, where the aim probably won't ever be cure, but there we're aiming to achieve stability, disease control, but maximising quality of life. And I think being able to do that with drugs that are able to be given at home, have fewer journeys into hospital, where people can spend longer amounts of time with friends, family, etc., is really important. So I don't think there's such thing as a single goal for everybody. I think it's different. But I think Cure Leukemia are very cognizant of that, and that's the sort of the different TAP studies which are being done include different groups of patients in different scenarios, which kind of encompass all of that, really.
And on that, how vital, and this probably sounds like a rhetorical question, but how vital is the charitable and fundraising support in the fight against blood cancer?
I think it's a really important part of it. I mean, you'd expect me to say that, but I genuinely think it is, because we couldn't do what we do without these various charitable contributions, funding research nurses, but also the fantastic amount that's done in terms of publicising research and just linking us all together. It's just been so cohesive that Cure Leukemia have been really good about bringing people together in the same room. And I think it's just really important.
And now we're bringing people together in the community that is the Patients Podcast. And Steve, there will be people watching this podcast from all corners of the globe who may have just had their AML diagnosis. It's probably not as simple as a message to them, but when they come to this podcast, looking at you, what might you say?
Yeah, it's very difficult to answer that in a soundbite, because having a conversation about acute myeloid leukemia to a new patient, as we've said, it's nuanced, it takes an hour or more, but I would say that you're going to become expert in your condition very quickly, quicker than you would believe. There are a lot of people that are going to be looking out for you. It's a real team effort. So clinicians, nurses, patient, family, everyone needs to come together, and it'll be a team effort. Your treatment will be something that will probably evolve over a few days or a few weeks. You're not going to know everything instantly, but it's going to be a journey you're going to be going on. There'll be lots of people to help you along the way with it.
People as passionate as you. Steve, if it were possible just to change one thing about, let's call it the system, tomorrow, what would you change?
Yeah, I mean, it's difficult because there are so many things which all interlink and influence different parts of the system, and there are so many things that are being worked on. I think something that's a bugbear of mine, which I would have thought it would be relatively simple to try to address, is trying to improve access of patients in slightly remoter rural areas to clinical trials. And I think what we've found in Wales, but I'm sure it applies to other parts of the country as well, is the way that the research system is organised doesn't really allow trials to be open on a sort of hub and spoke basis. So in other words, if I'm overseeing a trial in Cardiff and I've got a patient in a slightly more remote part of Wales, often it means they have to then transfer everything to Cardiff and do all of their trial visits in that hospital, which can be massively off-putting in terms of going into a trial, because there's no real way of having a trial open in two centres and allowing there to be shared cooperation, because the other centre doesn't tend to get any credit, and the way that metrics are worked out in the NHS, it doesn't really work. So addressing that, so so there can be more cooperation between sites, so that the so-called satellite centre gets rewarded and gets recognised. I think that would be really important.
Thanks, Steve. And you've been very generous to give us a real insight into you and what you do. How do you unwind from all of this?
I think I've got a very supportive family, very supportive wife, and I think that's the main way, really. that my wife's a medic as well, so we can share our experiences and sort of bounce things around after a tough week. What else do? I go out for a run, blow away the cobwebs a little bit and reflect during that time.
Professor Steve Knapper, thank you so much. It has been an absolute pleasure to have you on the sofa today. Thank you for sharing all of your experiences and your knowledge with us. Everybody, you have been watching Let's Talk Blood Cancer, the Patients Podcast.